for being with us, and I'm expecting amazing meeting, and we have very good lecturers this morning. And this is the following of the series webinars we are organizing as part of World Spinal Column Society. Meet the Expert webinars, and today we are going to talk about robotic spine surgery, which is a very hot topic recently. And we are very lucky to have two of the best experts in the area. We have Roger Hartel and we have Joe Butler, which will give us insights in the topic. We have also Mike Steinmetz from Cleveland, who is going to be moderating together with Sout El Fattah from Egypt. And I think we can start. So I suggest we start with Professor Butler. Joe, are you online? Okay.
I think he's not here.
Okay, well, in that case, probably we can start with Professor Hartel. Sout, do you want to start and present Professor Hartel, and then we start?
Sure. It's a great honor having you, Dr. Hartel, and it's very difficult to introduce a big name like this. We are very grateful that you are joining us and helping with the educational endeavor that the World Spinal Column Society is famous of. We do appreciate your time. Professor Roger Hartel is a professor of neurological surgery and director of spinal surgery at Weill Cornell Brain and Spine Center in New York. He is the founder and director of Weill Cornell Medicine Center for Comprehensive Spine Care, as well as a Weill Cornell Tanzania neurosurgery mission. He also serves as official neurosurgeon for the New York Giants football team. We would like to hear about that maybe later. This is very, very interesting and important. It's difficult to talk about your CV, which is too long. So if we talk about it, maybe we will have the talk on another day. Dr. Hartel is having a great clinical interest and focus on both simple and complex spine surgery for degenerative conditions, tumors, trauma, as well as biological approaches for disc repair and regeneration, which is very interesting as well. He's a world-renowned pioneer and leader in many, many invasive spinal surgery and computer-assisted spinal navigation surgery. He's actively involved in improving neurosurgical care in developing countries as the leader of Weill Cornell Global Health Neurosurgery Initiative in Tanzania. So there is a lot of things that could be told from your CV. You're not only a great surgeon, a great scholar, huge list of publication, but a leader of innovation and a leader of humanitarian effort as well by working in Africa. So this is a great story to be told, and we are really honored having you. And we are really looking forward to hear from you about navigation and robotics in spinal surgery.
Well, Professor Sout, that was a really kind introduction. It makes me blush. But I'm honored, and I'm very, very happy to be here and join you, everybody all over the world, I assume, on this educational platform. Professor Sout, thank you so much. And Nikolai, thanks for having me. Paolo, Dr. Steinmetz, great to see you again. And I will talk to you about navigation and robotics. I will talk a little bit more about navigation than robotics, but really what I think what I'm trying to do is I'm trying to make everybody understand that, at least in my opinion, they really belong together. I think it is not helpful, I think, to try to separate navigation from robotics, because at the end of the day, and that's probably the main summary of my presentation, at the end of the day, I think we can only really take advantage of new technologies if we understand the pros and cons and really put them together rather than trying to artificially separate those. So I'll talk about that. I am a consultant for BrainLab. I'll try to keep that out of my presentation, or won't let that influence my presentation, hopefully. And again, thanks for having me at this event. I am a neurosurgeon. I trained in brain surgery originally, and then when I made the decision to go into spine surgery, I was very uncomfortable in a way, because as a brain surgeon, when I trained, navigation just kind of became available, and I was a little bit worried that as a spine surgeon, I would never be able to use the microscope and never be able to use navigation again. And then what has happened over these last 15 years now is that I probably use the navigation and the microscope more than a lot of my brain surgery colleagues in the hospital. And I find that quite remarkable. My practice is primarily degenerative. We're a level 1 trauma center, but on the Upper East Side of Manhattan, we don't see a lot of really crazy trauma cases. So it's really primarily degenerative. There are a lot of spine surgeons here. So as a minimally invasive spine surgeon, it really kind of forces you to be good at what you do, because most patients get second and third and fourth opinions. And what navigation really has helped me to do in minimally invasive spine surgery is to really establish a practice, I think, that is going very well, and that really takes advantage of what navigation has to offer. So I'll talk to you about computer-assisted 3D navigation. We published a paper where we try to put all those technical gadgets and skills that we need as surgeons, where we kind of summarize those. If you want to become a successful spine surgeon, especially minimally invasive spine surgeon, navigation potentially can be very, very helpful and very important. In addition to, obviously, to other microsurgical technologies, skills, techniques, and then obviously patient selection, which is probably the most important thing that we don't talk about enough, in my opinion. So navigation is really one of the components that make you a successful MIS surgeon for sure, but I think it's really helpful for all types of surgery, complex spine surgery as well. And why is that? Well, we've shown that it increases safety. Safety, if you measure it as if you measure safety as accuracy of placement of pedicle screws, there are abundant publications showing that if you use navigation, and that's really any form of navigation, the accuracy of your pedicle screw placement in general is going to be much greater than if you don't use navigation. Now, I work now closely with Larry Lenke. We're merging our spine programs. And obviously, Larry Lenke is a highly accomplished deformity surgeon who doesn't use navigation, but he's been doing this for 30 years. And but I think for most of us who undergo training and have like the more normal experience, navigation will show a significant benefit. And even Larry admits that if he was again a younger spine surgeon, that he would certainly look into navigation. And I know you had him there as a speaker a few weeks ago. It is efficient if you use it correctly. If you get your team involved, if you practice, you can increase your efficiency in the OR, and it enables complex and MIS procedures. And then the other thing is that patients really develop an awareness of navigation. Robotics is obviously the catchphrase here, but again, it falls under navigation. And patients really, if patients have a choice between navigation and no navigation, they will always, or for the most part, they will make the decision to undergo surgery that's navigated or somewhat planned. And this is really the way I look at it: is there's imaging technology on one side, and the imaging technology can be 2D or 3D imaging technology. We're all familiar with fluoroscopy. You can navigate with fluoroscopy. That's a type of navigation to a certain extent. And you can even do computer-assisted navigation with fluoroscopy. You mentioned Africa. We brought a navigation system like that to Tanzania a few times, and it was very, very successful. Unfortunately, we couldn't leave it there, but the surgeons really liked that and adopted that within a few days. Then there's 3D navigation. There's the fluoro-based, like for example, the ZEEM or the ISO-C or the O-arm. That's a cone beam CT or fluoroscopy-based CT scan that allows you to get 3D type images in the OR. And then there's a true intraoperative CT scan. Various companies have those now that you can they're either stationary or you can bring them in and out of the operating room. And then you can use preoperative CT scans in the operating rooms, but then you have to get a preoperative CT scan, then you have to calibrate it to your anatomy in the OR, either with fluoroscopy or with surface matching. On the other side, there's navigation technology. So we have, for example, BrainLab, Medtronic, Stryker. They have software and hardware packages that allow you then to use that imaging technology information to navigate. And then that can be done 2D, 3D. Into that arena, then we have to add subcategories of that are robotics, augmented reality, virtual reality. So all this really is one package, and you really have to look at it as one package, because only then will you be able to really combine and really take advantage of it. And then in between, how do these things communicate? There's software, planning software, and that is also, I think that's becoming more and more important to really allow us to make sophisticated preoperative planning, but then also intraoperative adjustments, visualization, and so forth. So it's really exciting. Again, the most important thing is to remember this really is all part of one area within spine surgery. It's all part of the navigation. And I just show you a few devices, the intraoperative CT scanners now that are available. Samsung has a stationary intraoperative CT scan. BrainLab has this CT scan. And they have great intraoperative imaging quality, but they're a little bit clumsier, and not all of them can you really move from room to room. And then there are the fluoro CT, so that's the cone beam CT that I mentioned. Different companies have different devices. The beauty here is you can roll them in and out, you can navigate, you can get a scan. Even if you don't navigate, you just get a scan at the end, and then you can bring them out and use them for a different case in a different room. And then there are the navigation hardware, software packages, which actually contains the software that communicates between the surgeon and the imaging technology. And there are a few examples here. And they're really very, very creative devices. 7D Surgical is a very, very different technology that looks really interesting. I have not used that, but I encourage at meetings, once we have meetings again, definitely take a look at these, because they're really exciting. And then there are robotic systems. So robotic systems, for the most part, really work by, you have to do preoperative planning, and it shows you certain trajectories for pedicle screws. And that can be very helpful in patients with complex anatomy, but it doesn't allow you intraoperatively then to really use a pointer to identify anatomy. And that's active navigation allows you to do that. Now, if you compare the screw accuracy between those different types of navigation, so there's a study that was published a few years ago that compared pedicle screws placed with robotic, with navigation, and this refers to navigation with an intraoperative CT scan, so active navigation, ORM, so that's fluoro CT, and just fluoroscopy. You can see that the screw accuracy with any type of navigation was superior to the screw accuracy just with fluoroscopy. But it's also important to remember that there are no real big difference. At the end of the day, there are no big difference between robotic navigation and 3D active navigation, and that's really the point here, that it's all part of navigation, and if used correctly and accurately, there are no big differences. But there are certain advantages of robotic surgery over regular active 3D navigation, and vice versa. And we want to talk about those a little bit. I use in my operating room, I have an intraoperative CT scan that's integrated with the navigation system. So the table is attached to this intraoperative CT scan. And I've used navigation, as I mentioned already, as a resident when I was training in brain surgery. And then when I became an attending, I did my fellowship, I came back. I really made a conscious effort to integrate navigation into spine surgery. So I've been through the whole learning curve over the last 15, 16 years now. And initially we used navigation only for placement of pedicle screws. But then as the software and as the hardware, and especially now with the true intraoperative CT scan, where the bed is attached to the CT scanner, where the accuracy is really, really high and the image quality is really good, I found that I started using navigation for everything, not only for the pedicle screws, but I really used it for the skin incision, for placement of the tubular retractors, for the screws, for bone harvesting, for placement of the cage. So for every part of navigation, and we called that total navigation, and we looked at our experience initially. We used that for MIS TLIF surgery. So we eliminated fluoroscopy. Nobody wears lead. You navigate from start of the procedure to the end. Now that requires, of course, that you change things around a little bit. So I put in the screws first because that requires the highest accuracy. Because as you do the case, the accuracy deteriorates minimally, but somewhat certainly, especially once you put in the cage. So I put in the cage at the very end. The screws first, then the decompression, and then the cage. And that allows me to use navigation, the same spin for the whole case, for MIS TLIF surgery. And then we looked at all the other cases that we do: cervical, thoracic, lumbar, so ACDFs, OC fusion, thoracic discectomies, tumor removal, lumbar, different types of lumbar procedures. And we realized that with total navigation, we were able to eliminate fluoroscopy in more than 75% of cases. So really nowadays, the only cases that I use fluoroscopy for are lateral cases. I do a fair number of L-lift or X-lift type of procedures, A-lifts. For those I use fluoroscopy, but then for the part where I put in pedicle screws, I use navigation. And those are really the only cases I use fluoroscopy for nowadays. Now, we worked with AO Spine on a curriculum for minimally invasive spinal surgery, and we came up with a step-by-step procedure for MIS TLIF. And the MIS TLIF procedure is a great operation because it's very, very standardized. You always look at the same type points in the anatomy, and therefore it really lends itself to a standardization. And we did that within the AO, and I want to walk you through a TLIF procedure the way I do it in the OR with total navigation. So this is the intraoperative CT scan. This is the patient that is going to undergo the MIS TLIF procedure. I use a microscope. I tape a lot, okay? The residents always joke around that I should have invested in that company that produces the tape, because I'd probably be a rich man by now. I use a lot of tape because I think that, I do that because I rely on navigation for the whole case, right? So I got to make sure, and the taping allows me to eliminate the movement from the skin, especially in patients who are a little bit more obese, like this one here. Then I mark the iliac crest, I mark the midline here. We put the 2-pin reference array into the iliac crest, and that allows me then to navigate without having to move that reference array at least until T12 or T11 if I have a case where I have to go higher up. Certainly in the lower lumbar spine, this is, in my opinion, the best way to really accurately navigate. And then then we get an intraoperative CT spin. Everybody leaves the room except for the patient, so there's no radiation exposure to the staff. And then we use navigation to plan the skin incision. And the skin incisions, I make 2 skin incisions, one on the right, one on the left. The skin incision is planned in the perfect trajectory for the pedicle screws. So you extend this line to the skin, and that's where you make your skin incision. That then allows, when you put in the screws, that allows that you don't push against the fascia. You gotta consider all these little things that could potentially introduce inaccuracy. So that's one of the principles. You want to make sure you don't have to push against the muscle or the fascia to introduce inaccuracies. I used to use navigated drill guides. I never really used K-wires, but navigated drill guides I used to use. They were kind of custom made. And then these screws came out recently, and there are different companies now that make these screws. Essentially, these are very, very aggressive pedicle screws that have an integrated K-wire that you can dial out or in. So essentially, it's an integrated K-wire, but you don't have to navigate that separately. You just navigate this screw. It's a single step screw. And for most cases, unless somebody has really, really hard bone, for most cases, you can just navigate this and relatively easily penetrate the the pedicle and then place that screw. We just published our experience, and it really cuts down. The main advantage is that it cuts down on the time that you use use for pedicle screws. So instead of several minutes now, you can do this within 2.5 minutes, and that's an average number, including placement of the reference array and so forth. So per screw, once you're there, it's actually much shorter than that. And then we place, once we have the 2 skin incisions, these are the reference array and the iliac crest here, those shadows here. Then we place the pedicle screws, and then I harvest bone graft from the iliac crest. I do that through the same incision, and I use navigation for that. So we harvest nice. I use only autograft bone for MIS TLIF because we can get this nice autograft in these cases. And then and this is now from the curriculum, from the drawings of that published curriculum for MIS TLIF. Then the goal, and we're on the right side here, then the goal is really to harvest the facet joint to get access to the disc space. And again, it's always the same thing. You start at the inferior edge. This is the L4 lamina in this case. You drill or you use an osteotome. You go to the pars. You disconnect the inferior articulating process of L4 in this case, and you can use that for your bone as well. And I use navigation for the placement of the tubular retractor here. And this is just an example. Then you can, once you're looking through the tube, you can identify the pars here. You can identify the inferior edge of the lamina, which is where you start drilling. Or if you use the osteotome, you connect those 2 lines, and that allows you then to harvest the inferior articulating process of L4. And I use the drill. So I drill that, I harvest the bone. And then the next step is really then to identify the L5 pedicle and make a cut right above that pedicle to harvest the superior articulating process of L5. And again, navigation can help you find that pedicle. And this is a case I did last week. I just put that in here because this is an elderly lady. She's in her 80s. We did a 2-level TLIF here, and she had a previous laminectomy like 20 years ago. And navigation was really nice here because it allows you to identify the interface between the scar tissue and the bone. And that allows you then to safely drill down the facet here, and you always know where the interface is. Now, again, this is something that robotic surgery wouldn't allow you to do. Robotic surgery allows you to place the pedicle screws, but you really need both. And the new systems now, the new robotic systems integrate active navigation and robotic navigation. And that's my point. I think to really take advantage of it, you need an integrated system. So if you have a robotic system that doesn't allow you to use active navigation, you're really losing out on a lot of the benefits of navigation. So now you get down to the disc space. Then we navigate the cage. We place the cage through a tubular retractor. We can simulate the cage here with the software. And then if you have to do an over-the-top bilateral decompression, you can do that. Again, you can use navigation to help you get to the contralateral recess, to the contralateral foramen, especially if you're in the learning stage of doing this operation. Navigation at this part can be very helpful. We call that over the top decompression. I'm not going to go into the videos because that's not really the point of this presentation. And then that's in that particular case, that was the X-ray post-op. Now, this is the paper that we recently published on using the single-step navigated pedicle screws. And they're really very, very helpful. Like in this case here, for example, we got an intraoperative CT scan. We noticed that pedicle screw was too lateral. So I used a navigated, that particular company has a navigated all tap. So we drill a second hole just medial to that laterally placed pedicle screw. We drill the hole with the tap, we mark it, we remove the old screw, and then we put in the same screw into that pedicle screw, into that pedicle hole medially, and that's the CT scan after we did that. So it looked very accurate. So navigate, again, that's something that that modern navigation really allows you to do. Or in this case here, where we did an ALIF, and that screw that we use is kind of in the way of the pedicle screw, but you can kind of navigate around that by using that all tap. That's a very aggressive, very precise instrument. You can mark the hole that you create for the pedicle screw, and then you can put in your actual pedicle screw. So it's a delicate process. So you got to be very careful. Don't push too hard because navigation obviously can be off. So you got to be very, very delicate when you use this. I want to show you one case here. where we use navigation in a little bit of an awkward position and patient in the lateral position. We do more single stage cases where we have a patient who needs an anterior approach or lateral approach, where we keep that patient in the lateral position and then do the lateral, the anterior approach, and then also pedicle screws in the same position, so single stage surgery. And this was a great example. This was a patient at previous L4, L5 fusion, and we wanted to extend to L3-4 and L5-S1. So we placed the patient in the lateral position. This from the front. We did a single stage ALIF from the front and the lateral then at the level above, and then and that we do with fluoroscopy. But then we navigate while the vascular surgeon is closing in the front. We start putting in our pedicle screws from the back with navigation, and that's a little bit awkward, obviously. And maybe that's where robotic surgery may have an advantage, but we're certainly with a navigation, this is very, very feasible. And you just got to make sure again that you really stabilize this patient. And with these single stage pedicle screws, this becomes a very, very straightforward procedure. And that was the final X-ray. Now, we also do tubular decompression in the lateral position. So some of these patients may still require a decompressive laminectomy. So we drop a tubular retractor in the lateral position, and that can be facilitated with navigation as well, as shown here. And that's actually very, very straightforward. Finally, I want to show you a few pictures about augmented reality. So we started integrating now into the 3D navigation augmented reality. And so it superimposes computer-generated images over the over whatever you're looking at. So you can use these glasses, or you can look at the screen, or you can look at the microscope. But you can always insert augmented reality into your visualization. I use the microscope, and I want to show you a MIS TLIF where we use, and the microscope is navigated. You can see the reference array here. So we're doing an MIS TLIF procedure here. And I mentioned before that MIS TLIF is a totally standardized procedure. You always look at the same anatomical landmarks, but they can be hard to find if somebody has severe arthritis. Finding the inferior edge of the lamina, the pars, the facet joint can be quite difficult because of the individual changes, but the landmarks always remain the same. So what we do is that we identify the bony landmarks on the intraoperative CT scan, and we mark them in different colors, and then project them into the visualization. And under the microscope, then when we drill, we can see the pars, we can see the lamina. In this case, we can also see the pedicle screws that were already placed as a first part of the operation. And then we use those, and my fellow marks the pedicles here in different colors, the lamina, the pars, the disc space, the facet joint. And when I come in, I bring in the microscope, I place the tubular retractor, and now I can see I can see the inferior edge of the lamina here, the disc space, the pedicle above, the pedicle below, and this is the pars. We still have to figure out exactly what colors to use so you can really see it very, very clearly. We're kind of playing around with different colors, which is quite interesting also. And so we're trying to get to the point where you bring in the microscope and you see all the relevant anatomy immediately, or at least you kind of know where it is. And then you obviously still have to drill bone, you have to remove osteophytes and so forth to get there. So this from the right side, and this little red dot here marks the inferior edge of the L4 lamina, and this is the pars. So I know that I have to connect those two dots in order to disconnect the inferior articulating process of L4. And this is the facet joint that was marked. So we're playing around with this right now. We've done about 10 cases, but it's an attempt to kind of take advantage of technology. And I think that once we get really fast, and right now it takes maybe 10, 15 minutes out of your case because you have to pause every once in a while when they're marking things. But once you really get this figured out, I think this can be very, very helpful, at least for training and teaching purposes, you know. So this is now, this ligamentum flavum, we disconnected this. This is the facet joint that we're mobilizing now. We made that cut from the lamina to the pars. And now we're looking at the L5 pedicle here. And now the disc space is underneath here. And then now we're projecting the disc space into the picture. And and so forth. So it goes on and on. But you know, we get so that's one way of using augmented reality. Obviously, other surgeons use it with goggles to put in the pedicle screws, which is also great. I was always more interested in microsurgery, so I kind of thought that this would be helpful. I'm not going to go too much into this. I use it for ACDF surgery as well, but I'm running out of time, so I just want to basically reiterate that I think the most important thing, especially for young surgeons to understand, is if you really want to become a successful spine surgeon, you got to understand that technology is your friend, and don't let the companies or others tell you that robotic is different from navigation. You got to look at it as the whole package. So there's robotics, there's augmented reality, virtual reality. If you really, really want to take advantage of the technology, you got to look at it as a whole, and you got to figure out what are the pros and cons for individual pieces here in your surgery. And I think that you know, the concept of total navigation is really interesting, that you can totally eliminate fluoroscopy. Robotics is great because it kind of gets you used to the concept of planning things and automation, and then augmented reality, see-through technology. So those are the kind of like the three areas that I find really interesting. And again, thanks for your attention, and I'm really excited to be part of this.
Thank you so much, Roger. It was a really amazing presentation. This is how I always known Roger Hartel. I met him first in 2013 in Austria. And since then, I know him always being on top of the technology, riding the wave. So really, really good presentation. Thank you so much. I hope this was interesting for the rest of the presentations. So the rest of the participants of the webinar, and I really would like to point your attention. Be very careful. This is for the juniors, because at the end of the webinar, I'm going to ask you one question, and you will have to give me the correct answer. And then if you give me the correct answer, I will have a surprise for you. So now we can continue probably with Mike. Mike, do you want to present Professor Butler?
Absolutely. Thank you. Thank you, Nikolai. So it's my honor to introduce Professor Joseph Butler, Joe Butler. He is a consultant orthopedic spine surgeon who does both academic teaching spine surgery as well as complex spine surgery. He trained at the Royal National Orthopedic Hospital in the UK, but also spent time in training at Beth Israel in Boston and the Rothman Institute in Philadelphia. He's a full-time consultant at the National Spinal Injuries Unit. And I think, is it Mater University Hospital, Mater Private Hospital in Dublin, Ireland. He's been there now for over 3 years. And what's interesting about Dr. Butler, what we're going to hear about, is he set up the first robotic spine surgery program in the UK and Ireland at the Mater Private Hospital. So it's going to be very interesting to hear about his sort of experience, because he's going to talk to us about setting up a robotic spine surgery program in your hospital. He's the clinical lead for robotic spine surgery at the NSIU. And they're about to launch, and maybe they already have, the first robotic spinal navigation program in UK and Ireland to include both navigated microsurgery and augmented reality platforms. He's also the secretary of the Irish Spine Society and a member of the Robotics Navigation Committee of NAS. He's a prolific academician. He's published over 120 articles and 26 book chapters in one book in the field of neurosurgery, including over 155 scientific presentations. And is funded with over 3 million euros in research funding to date. So, Professor Butler, it's an honor to have you here on this webinar, and we're very interested to hear about setting up a robotic program in our hospitals.
Thank you very much, Michael. So, pass the screen to me. Can you see that?
Yeah, if you can share, Joe, yeah.
With
I don't see you as yet.
Wait there.
There should be a green screen. There's a share screen green button at the bottom of your screen. It's just, if you just press that, and it will be possible to share your screen.
Nikolai, we don't have to allow him to share. It should just be automatic, right?
Yes. It should be automatic. Yeah.
Let me see if I got it working.
Could we take a couple questions for Dr. Hartel while we get the screen on, or do you want to hold?
Oh, maybe while we are doing that, we can, Imad, do you want to share the screen of what we are organizing soon? So I'm delighted to present to the audience that we are organizing a series of certificate courses in 2021, and the first one is starting very soon. This is part of the initiative of the World Spinal Column Society of increasing the knowledge of our members, and you can see on screen now the benefits that these webinars will be. You will have the following benefits when you attend these webinars and when you subscribe for these courses. We have decided to keep these courses for our members, but it is very easy for you to become a member of the society if you're interested. We have high quality teachers that we managed to gather for you, and you can see that it's going to be really beneficial for you to be part of this program. At the end of the program, you will have a certificate which will certify your attendance and your achievements. So I really urge you to consider strongly and to be part of that. And remember, I told you that there will be a surprise for one of you, one of the juniors, at the end of this session. So be careful and just be mindful of the presentations. Joe, you're ready to go?
I'm struggling a little bit. The screen share won't seem to share with me.
Maybe, so now Imad, probably if you unshare, then Professor Butler will be possible. Do you want to try now?
Okay. Doesn't seem to let me.
Normally, it's very easy to do so. If you did you find this green button that is share screen at the bottom?
Yeah.
So you can click on that. You see, sir, you can click on the green share screen button. Then there is an option share screen. So you can click on that screen as well as the presentation window.
Won't share screen.
Is your presentation too big, do you think, to email? Could it be emailed to maybe Nikolai or something, and then we can run it off of your computer?
Yeah, I can send an email right now. Yeah.
Yeah. Okay. So we can do that. I'll be ready to play it.
Sir, can I share the video meanwhile?
Yes, Imad, please do that.
Sure.
Hi guys, how's everybody?
Good to
see you.
Hi.
Roger, a great talk, thank you.
Great. Good seeing you. How are you?
Not too bad, I'm doing well.
Good morning. My name is Iago Kastan. I'm the chair of the Department of Neurosurgery at Brown University in Providence, Rhode Island, United States. I would like to welcome you, World Spinal Column Society, pearls from the OR certificate course.
Society's mission is to advance spine care worldwide by connecting spine surgeons.
It's of 3 parts on tumors, deformity, and cervical trauma. It's a great opportunity not to be missed.
The first will be held on spine tumors and will take place on March 20th and 21st of 2021. The first time the conference will bring pearls directly from the operating room to the audience from the world's experts.
It will be case-driven presentations over 2 days in both pediatric and adult malignant and benign tumors.
Don't miss the keynote lectures by 5 world-class spine tumor surgeons: George Jallow, Lawrence Rhines, Diego Kazlan, Liliana Engelov, and Mark Wilson.
Come and join us. Become a member of World Spine Column Society and attend all 3 spine certificate conferences for free, along with other benefits.
Let's bring the world of spine together. I will see you on 20th of March.
We look forward to you being able to join us soon.
I hope that it will be a very valuable experience for everybody who participates.
Thank you.
Are we there, Nikolai?
Yes, so we are working on sending it, but obviously it's a presentation that will not be. It's a bit big, so it's a work in progress, but it will be a few minutes.
Couple of moments, yeah.
Yeah, Nikolai, could we ask Dr. Hartel some questions, maybe through the chat box? We could moderate the chat and ask some questions.
Absolutely, yeah, absolutely. This is something that will be definitely good. So let me see if there is any questions from the chat, or maybe if anybody wants to ask questions.
So I'll kick it off. Roger, first of all, great presentation, as always. The way you detail just sort of the MIS TLIF is phenomenal. I use your illustrations a lot, so thank you for the work you put in. My question to you would be around barriers to navigation, and the obvious is cost. But if we take out cost, it's still not really. I mean, it's not really become sort of standard of care, I guess, yet. It's sort of creeping its way in. What do you think, outside of cost, is the biggest barrier for just applying spinal navigation and MIS concepts just widespread?
Yeah, I think that's a good question. I think it's really the workflow and the teaching and training that's really necessary to really make sure that surgeons understand how to integrate it effectively and safely. You know, and I've seen it in our group. You know, our spine group has kind of slowly grown over the last 10 years. You know, we added faculty, and everybody who came on board really within a short time period, even though they didn't navigate before, they started using navigation more and more. And I think that the reason is that they came into an environment where we kind of had it all figured out. You know, the nurses knew it. You know, we had the navigation systems here, but then we purchased more over the years because there was just a demand. So we kind of made it easy. And now, I mean, it's a little scary, but now sometimes people cancel cases if the navigation is not available. So it kind of creates, you know, you got to think about these things, and you got to, you know, the question then is always, well, you know, it's like with brain surgery. When I was a resident, I'm sure you too. I mean, people say, you know, you don't learn, you know, you kind of forget about the anatomy. I don't really think that that's the case. I think that if you, and then there's always going to be a mix. I think most surgeons are going to be trained in both still, at least for the next 10, 20 years. So I think people should really have an exposure to both. But those are all important questions. But what I see is, like I said, I mean, most surgeons who are really who are busy spine surgeons who use navigation, they don't want to miss it, and they really see a benefit in it. And the reason why people don't pick it up is because they're not exposed to it. So the lack of training, and that's really up to the societies and the companies to kind of treat that, to address that.
You said, Nikolai?
Yes. Okay. I have the
bottom on the right. Your screen, you know, just the slideshow is at the bottom on the right. Could you bring it down?
Yes. Yes. I'm doing this now.
Brilliant.
Okay. So seems like we are cooking. Okay.
Can you see my slides? Can you see? I think I should be able to share there.
Yeah, we can see it good.
Can you see my slides?
Yes.
Yes, I think everybody can see now.
Okay.
Can I go?
Yes, please. Yes, please,
Okay.
Joe.
Thank you, guys. Apologies for that now. And thank you very much for the introduction, Michael. And that was a superb talk, Roger. So yeah, just to summarize, I'm an orthopedic spine surgeon based in Dublin, Ireland. And yes, we were the first group in the UK and Ireland to set up a robotic navigation program. And we did it at the Mater Private Hospital, which is a predominantly elective degenerative-based practice. And that's been in existence for about a year and a half now. And we're about to launch in the major university centre, which is a tertiary referral centre for spine surgery in Ireland. We're going to set up another robotic programme, and it'll also include navigated microscopy, which I'm sure Roger is excited about, and potentially the AR and VR components to that. Now, when setting up a robotic spine surgery program, there are a couple of things you need to consider. Firstly, the patient, secondly, the surgeon, and then thirdly, management or administration. In relation to the patient, robotics offers certainly the potential for a much greater patient safety, brought through accuracy and less complications, and allows patients to have a fast recovery because it's allowing us to do more minimally invasive surgery through smaller incisions with less muscle damage. In terms of the surgeon, it's allowing us the potential to improve our dexterity, to eliminate that tremor in a prolonged case and reduce fatigue. And it allows us really to do those more technically challenging cases in a much more minimally invasive fashion. And it allows us to do more complex surgery, such as revision surgery and deformity surgery, in a much safer, more efficient way. And as we know, it allows you the potential to have 3D real-time imaging of instruments in space when doing complex surgery. In terms of management, and this is crucially important if you're going to acquire something which has a large capital expenditure, it's important to look at the various aspects that are of interest to management. So certainly, you're looking at cost effectiveness. So you want to look at, are you reducing OR time? And certainly there is a learning curve associated with taking on robotics. And certainly I've been through the pain of that and out the other side, but certainly it's going to add time to your operative time with doing cases for the first number of cases. But then as time progresses, as the staff get good at it and your workflow gets good, you really find that it's a very, very efficient way to put in implants, be it pedicle screws or cages or whatnot. From my own perspective, certainly management like to hear that there's a reduced length of stay associated with use of robotic surgery. Certainly in the private sector, in our country, the hospital gets paid a bundle payment for somebody that has a fusion surgery. So if the patient stays for 7 days or 2 days, it's the same payment. So sadly, open fusion surgery in our elective degenerative hospital has a length of stay of approximately 6.1 days. However, having introduced the robot, those patients are going home at 3.4 days. And I've had 5 patients over the past 2 months that have gone home on day 2. So certainly if management and administration are able to turn over those beds, they can put in additional hip arthroplasties or knee arthroplasties or further spine surgery. That's a win-win for them. And so that's a big sell. In terms of the marketing potential associated with it, certainly you're able to market your center as a robotic spine surgery center. You can really market it as, offering minimally invasive surgery, minimally invasive techniques, and also you're looking for that business in relation to complex spine surgery and offer the ability to do that safely through use of robotics and robotic navigation. The system we ended up plumping for was Globus Excelsius GPS. It works well. It was a system that we felt worked well in a degenerative setting and would have a good footprint and would work well within a high volume elective center. Now, certainly if you're going to consider what robots you get, there's a variety of things that you want to look at. Certainly this particular robotic platform offers the multifunctional robotic navigation, allowing you to have greater accuracy and allow you to do more minimally invasive techniques. And certainly the more minimally invasive the surgery is, you're allowing that enhanced recovery and earlier discharge. In terms of the imaging versatility, which certainly Roger mentioned, it allows you to visualize, plan and navigate patient anatomy in real time. And there's a number of workflows which have been alluded to, such as intraoperative CT, preoperative CT, and intraoperative fluoro. In terms of what worked well for us, I really wanted to do intraoperative CT scanning. We went with what was the Zeem 3D C-arm, which has its pros and cons. Certainly has a much smaller footprint. It's lightweight. It can be easily stored. I will admit it does not quite have that degree of that impressive image quality that you would get from an O-arm, but certainly worked well in a high volume degen center where you're doing kind of single 2-level, 3-level fusions. Preoperative CT is something I would probably consider more if I was doing more of a kind of elective deformity type setting. I think that would work well from that perspective. And then there's also the potential to use intraoperative fluoroscopy.
Professor Butler, would you please guide me? When do you want me to change the slides? So if you just say next slide, then I'm gonna.
Next slide, yeah. So in terms of launch of a robotic program, certainly you want to certainly explore all of the robotic programs that are available. Certainly I would advise anyone who's interested, go see demonstrations, go see them live in a sawbone setting, to a cadaveric setting, to a clinical setting. It's important to certainly investigate how they work, and are they going to be a good fit for your institution. Things that you're going to consider are, do you want a freestanding movable platform, or do you want something that's going to be a bed mounted? Next slide. In terms of surgical visitations, once you've selected the program that you're going to go with and which platform you're going to use, I would certainly recommend visiting surgeons that do this at high volume. Certainly when we purchased our system, I went to San Antonio in Texas and saw a surgeon who had done well over 100 cases and had a really efficient workflow. And certainly visiting these guys and girls allows you the opportunity to really get up the learning curve in terms of getting your workflow down, because the workflow is absolutely critical. It adds an enormous amount of time to your surgery, and the quicker you get that workflow efficient, the much easier it is for you to perform the surgery. I also felt it was worthwhile seeing a surgeon that was earlier in the learning curve, and certainly Alex Vaccaro is a mentor of mine, and he was at the earlier stages of taking on robotics, and seeing somebody who's, getting through those early stages and trying to get the workflow down and troubleshooting the various aspects of it is hugely important. So I would recommend certainly seeing somebody who's done well over 100 cases, and potentially seeing someone who's newly installed the platform. In terms of cadaveric training, it's crucial that you bring as much of the team as you can to a lab. It's important that you bring the OR nursing staff, those that are going to be right beside you in theatre, and your main team with you, and certainly the radiology technicians are crucial. It's important that everybody on the team gets comfortable with the robot, with the software, with the hardware, and gets comfortable with the workflow, because the more comfortable your staff are with this, the much easier it is to introduce it as a new technology. Then moving on to multidisciplinary training. When you've got the robot platform on site, it's crucial that you bring everybody who's involved in the care, involved in the training. So certainly we brought everybody from the portering staff who got an understanding of the patient setup, anesthesia, had an understanding of what it involved in terms of occasionally doing breath holds and what the surgery involved, and certainly getting the nursing staff, the OR staff, the radiology techs involved certainly made things an awful lot easier, and allowing everybody the opportunity to ask questions and understand what's happening at each different stage. Then we did a number of trial runs. So certainly we brought a sawbones model down to the OR, and we did a dummy run twice, whereby it was a fake patient basically. It was really useful to see what side you'd be using the robot, what side you were bringing in the imaging platform, and just getting comfortable with the setup in the OR was really helpful. I would encourage that big time before starting on your first number of cases. And then it's really crucial to consider judicious patient selection. It's important that you pick patients that are not going to be technically challenging, but are also patients that want to do well, and patients that are going to do well. So it's important that you pick really well the first few patients you do, because it's extra work from your perspective. It adds a bit of time to the case. It's a little bit of additional extra stress, and having a patient who's on board with this, who's a well-fit patient, is very important. And then as you progress through the cases, you can expand your indications from doing simple single level to 2-level and beyond. And certainly the more comfortable you get using the robot and the more efficient you get with your workflow, the more you're able to expand those indications. Now, in terms of our case series, I've done about 80 cases now at this stage. They're all degenerative lumbar spine cases. And there's 2 surgeons at my center using it regularly, and there are 2 surgeons who are using it less regularly. I would certainly recommend, if you're going to take on robotics, you need to embrace it. It's crucial that certainly I use robotics for every single pedicle screw I put in that institution. It keeps me slick at it. It keeps the staff comfortable with it, and it really keeps the workflow very, very good. Just a couple of cases I'll briefly discuss, which you are well selected for the beginning of potentially taking on your program. This is an example of a 65-year-old gentleman who had a 2-year history of bilateral L5 radiculopathy, low back pain, progressive reduction in mobility. Patient presented with neurogenic claudication and bilateral L5 radiculopathy. He had a mobile degen L4, L5 spondylolisthesis. So a perfect case to potentially start off on somebody that would do well with a simple single level decompression and fusion. And for my initial cases, I started off doing going a step back and doing intertransverse fusions until we've now moved forward to doing interbody fusions with navigation. So certainly those type of cases are patients that do well to start off with. And next case was a 58-year-old gentleman who was newly retired from the army, who was really struggling over the years, unremitting low back pain, had 2 degenerative discs, failed all non-operative intervention. You can see on X-rays and MRI, he's got 2-level degenerative disc disease. I also got a SPECT CT scan showing both levels lit up, consistent with potential pain generators for him. So next slide. And so this gentleman had a 2-level minimally invasive instrumented fusion. Case took about an hour. The guy was mobilizing day 1, was discharged on day 3, and 6 weeks post-op, he's no back pain. So he's super delighted. He's doing really well. A patient that wanted to do well. And then another case worth thinking about, certainly I think, and we don't consider enough, these patients that have malignancies are absolutely great cases for use of robotics. This was an example. This was a 72-year-old lady who had metastatic ovarian CA, and you can see she has an L3 compression fracture. She had been struggling to mobilize and then had in fact been bedbound for approximately 4 weeks, unable to weight bear. She was 2 weeks post radiotherapy. And so I felt she would benefit really well from an instrumented fixation, 4 1-centimeter incisions on radiotherapy tissue, 0 blood loss. Case took 45 minutes. Post-op, day 1, she's mobilizing for the first time in over 4 weeks. And this is a big deal for somebody who's at the latter stages of life in terms of quality of life. The ability to allow her to mobilize in the latter stages of metastatic disease was a big deal for her. She was transferred to her oncology center at day 2, 0 post-operative issues, but the ability to be able to mobilize was a big deal for her. Next slide. Okay, that's it. Thank you very much.
Okay, let me unshare now. Thank you so much, Professor Butler. It was a very insightful presentation, and it was good to see somebody who has started relatively recently with that, and as you said, struggled through the teething process of that. Can I ask you a question? The case that you presented first, and you said you have to go a bit step back. What did stop you to put also interbody cage to that? Was that deliberate, or it was just something that you?
Yeah. So yeah, certainly. So it's deliberate. So I would be a very big fan of T-lift surgery, and certainly that was I'm a big fan of doing interbody cages, and certainly if I have a degenerative spondy and I'm doing surgery, it would be a T-lift. But certainly the workflow associated with taking on robotics is increased. So the operative time at the beginning is longer, and I think my decision was, in the early number of stages that I've taken on, was to take a step back from the additional component of having to put in an interbody cage, because I felt that it was adding an additional time to the patient. And I felt that by getting the workflow quicker and faster, we would be better prepped then for moving on to then doing navigated interbody cages. Now, so in my additional center, I do open navigated surgery all the time, and I do navigated T-lifts. But at the center where I have the robot, I suppose moving on to the next stage, which will be interbody solutions, we'll be ready to roll and start doing interbody cages from that. But I certainly did take a step back, and that was certainly deliberate in the first number of cases that I've been doing.
Thank you. Is there any other questions? Mike?
Joe, I have a question for you. First of all, great presentation. I think of many centers are either starting a robotic program or looking to obtain a robot. So seeing your experience, I think it's really been helpful to try to understand, and even the flow to work through it. You guys were very diligent about, even bringing sawbones and dummies down to figure out how to make this work. So thank you for that experience. But my question for you would be, and if I missed this, I apologize, but can you talk about the differences, at least in your experience, by using your robot with a preoperative CAT scan versus an intraoperative image acquisition with whatever device you have, O-arm, Zeem, whatever you're using, intraop CT? Are there big differences for you, certainly in workflow or even accuracy?
I think probably it comes down to registration issues. So I think I don't know, maybe Roger has a different experience with this, but certainly there's a little bit more in terms of registration difficulties I find with preoperative CT scan. I think doing intraoperative CT scan matches quicker, and I think there is less issues. However, there are a variety of issues in relation to the Zeem 3D C-arm we use. We struggle in a very big patient, because I think you only have something like 11 centimeters from skin to pedicle. And sometimes if the patient is very, very big, it struggles to get in that, get the reference frame and get everything within the shot. So there is struggles in relation to that. Certainly that's zero issue if you're using an O-arm, and preoperative CT would certainly eliminate that. Fluoro, the issues which you did mention about fluoro, certainly with the platform we use, the industry guys don't have the ability to use it on a flat panel machine, surprisingly. So it works well for regular C-arms, but they haven't matched it with a flat panel C-arm. So that's a problem for us.
Yeah, it's Roger Hartel. Can I ask a question real quick?
Yep.
No, a really nice presentation. It's if I understood you correctly, you've got two setups. In one hospital you have, and then the robotic in the other. If you were to kind of design your perfect navigation system, what would you pick from one and the other, and how would you put that all together?
Yeah, so I mean, I work in two centers. So I'd say 95% of all my screws go in navigated in some variety. So I'll use Stealth O-arm in one center in the complex university center, and then I use Robotics in the other center. Certainly there are, I suppose, getting to the point slowly, certainly there are limitations in terms of the robotic platform, which you mentioned. It's been frustrating that we haven't been able to freehand navigate interbody cages, whereas I can do it with O-arm Stealth. And I think your entire point in relation to you've got to be able to blend the two and merge the two is crucially important. And I think there are restrictions, limitations within the current robotic platforms that don't allow you to do that. But you should be able to drop down screws, robotic guided. You should be able to jump essentially to a free nav to put down cages.
I thought the Globus system had that now. Is that not the case, though?
It does. You can navigate free, but it's a little bit more cumbersome. And certainly, I suppose their next iteration, which will be the interbody solutions, will be a little bit better in terms of it'll allow you the ability to have that retractor and do your MIS cage.
I got it. Yeah.
Tell me a little bit, Roger, can I ask you a question? Can you tell me, for my own interest, a little bit about navigated microscopy?
Well, you mean the augmented reality?
Yes.
Yeah. So, yeah, I mean, you have
vascular segmentation.
Yeah, the segmentation now, I mean, there are softwares out there, and I know that BrainLab has one that we're about to get that, where you get an intraoperative CT scan, and then the machine tells you basically L1, L2, L3, L4. That's out there. I haven't used it yet, but what the software does right now, it can mark, for example, the pedicles. You know, it can show you the pedicle, the spinous process. I mean, these are all things that are really coming now. If you want to use it with the microscope, you have to navigate the microscope, and you have to have a certain setup with your microscope that allows the microscope to be navigated. So you got to talk to your imaging company and the microscope company that they equip the microscope with a reference array, and then you can navigate.
Where's the reference array go? You know,
I had a picture in my talk. It goes next to, I mean, basically, if that's the headpiece of the microscope, it goes like on the side. You know, there are various solutions to that. We have a Zeiss. You know, it has like an attachment.
There are software. Yes, there are software you can use to navigate on the microscope along with anything that you have.
Right.
Yeah, we do in Belfast that for we do that in Belfast for brain surgery. You can attach the array to the microscope, and then basically that gives you some augmented reality. However, we haven't done it for spine as yet, but this is a good idea. Yeah, so there is an interesting question from the participants in the webinar. I just wanted to ask Joe about that. I know that your robot is installed in a private hospital. So the question here is, do you have any problems with patient volume in a private institution? In other words, is that adding extra cost? Is that adding extra problems for that? Joe, that's the question to you.
In terms of current COVID times?
No. So basically, usually these systems are the question that how I understand it is these systems are expensive and they take a lot of resources. And I know that your robot system is in a private institution. Is that a problem for you?
Not really. I think certainly what you'll find in this part of the world, getting going with technology is easier to gain traction in the private sector because the capital investment is much easier to justify, because the hospital works based on case volume, and certainly if you can demonstrate the ability to, as I mentioned, improve OR time, increase workflow, and certainly get patients out quicker, it's an easy sell to managers to purchase it. And I think certainly it allows the surgeon the ability to get trained on robotics and then ultimately introduce it to the NHS type practice or the government system. And I think it works well from that perspective. And I think it also, in terms of the patient mix, the case mix, there tend to be more simple degenerative type cases, which are great cases to start on. And I think it's a good training ground before bringing something like that to more complex surgery.
Nikolai?
Yes.
Can I have a question, please?
Of course, yeah, please.
Okay.
Go ahead.
First of all, I would like to congratulate both our distinguished speakers on the great presentations. Thank you for the great effort put there. And I will try to make the voice of centers that do not have this technology and want to introduce it heard. Usually there are four points of debate when you try to introduce something like that. And it was the same for even the minimally invasive techniques and so on and so forth. I will just try to summarize this. When you try to talk to the CEOs and the government to put this into action. First of all, the transient phase, when you are introducing this technology and you want to apply it, there should be some more lengthy operations because of the learning curve. So how to deal with this transient stage, and is this transient stage have a recorded more complications as well? And the way of dealing with these complications, could you do this with the same technique, or you have to do open complication dealing in every case? And the difference in the cost per case, this is going to cause. And the last thing is, we have very, very busy centers in Egypt, for example, that if they adopt this technique, that would influence everyone. But for a center that wants to start, and it's going to be the first center to introduce this into a country, the maintenance is a problem, because no company is going to put huge investment on one center working with this technique. So is there a problem with the maintenance and dealing case by case if you introduce this technology? This is a lot of questions, but it's always there when there is a technique introduced against what people think as a gold standard. So would both our great presenters tell us their experience when they build up this experience as a new experience in a center which is busy enough but wants to convince people to go this way? Thank you.
Yeah, I can say a few words. You know, the financial advantage of using navigation comes into play. I mean, based on the literature and based on some of the experiences that I've had, you have to have a certain volume of spine cases, obviously. You know, if you do like 10 spine cases a year, it's never going to get there. But if you do hundreds of navigated spine cases, the advantage comes in because of the reduction in revision cases, because you get, whether you use navigation or not, once you have the technology, you always get a spin at the end of every case. You may not even use navigation, but you use the technology that you have to get a spin. So you pick up screws that have been misplaced, and you can revise them then and there, rather than getting a CT scan the next day or waiting until the patient has a problem. Then you get x-rays, then the patient comes back and you have to revise it. There's a real financial advantage of doing these spins intraoperatively and then revising them then and there, rather than waiting and then having to take the patient back with all the financial costs and the embarrassment to the surgeon and the system, you know, to have these patients come back. So the studies have shown that that is the financial incentive, and that's where the cost reductions come in. But obviously you need a certain volume of cases to really see that benefit. So, and then you need maintenance. You know, if you don't have a system in place that allows, because these things break down, so you definitely got to make that very, very clear with the companies. And then the system in the US is so different from the rest of the world. But we looked at the surgeon reimbursement. There's a code when we code these cases that we use to get paid for navigation, and we just in our hospital we reviewed that, and we actually get reimbursed for using navigation as a surgeon. I didn't even know that. We just ran the numbers a few weeks ago. And I can if we get reimbursed as surgeons, that means that the hospital gets definitely reimbursed, because they're getting much greater share of all these costs. So I think financially, and I don't know how it works in your country, but there is a way to get reimbursed for navigation as an institution and also as a surgeon, and that's something that you may want to look into.
And about the period when the learning curve is still there and you have more lengthy operations and a little bit more complications, maybe, what did you do with this transient stage?
Yeah, I don't know. I'm not aware of really complications that are necessarily related to this, unless you're totally off and you're putting in screws. You know, if your navigation is totally inaccurate, obviously. But again, you get a spin, you pick it up, you see it right then and there. You don't wait until 5 days post-op. So I don't see more, but the timing, and I think that's something you can practice even outside the OR. The workflow of navigation is something you can practice with your team. You can walk them through the process, through the workflow. You can practice it on a weekend in the OR or off duty hours, and really make sure that everybody, the workflow is the key, and that's something you can practice. You don't have to do a case necessarily.
Okay, thank you so much, Dr. Butler. Can we share your experience with those 4 points when you're trying to build up a system?
Yeah, I mean, certainly I can't deny that it does add operative time to a routine case doing it, but I think repetition makes you faster and makes the entire team much more efficient, and I think that is important. I would also recommend when you take on robotics, I think you should find some friends who are also taking it on or have recently taken it on and share cases. Because certainly the most valuable points I've picked up that have changed my workflow have been from being at meetings or talking to other users. And I think user groups, official or unofficial, are really worthwhile doing, because you'll find, I used to start doing my surgeries, I'd have 3 incisions. So I'd have an incision on either side to drop my perc screws. I'd have a mini incision in the middle to do a decompression. And then I was finding that was taking forever to close and the exposure wasn't as good. And now I do 1 midline incision. I do less convergent screws. So I do more straight on screws and I get my decompression at the same incision, but my screws are put down percutaneously. So by talking to other high volume users, you will find a workflow that works well for you. So for example, I used to put I think you're supposed to put the surveillance marker and a DRB on the iliac posterior part of the iliac crest, where I think Roger has his. But I found I used to struggle significantly putting down 5-in-1 screws because there'd be a bit of clashing. So now I put my surveillance marker and DRB way out wide on the edge of the iliac crest, and it's never a problem. And so you'll find from talking to different people, they've kind of found their own techniques that work well, and you'll find ways of getting that workflow a bit quicker. So talk to a lot of people. And the reps don't necessarily know the answers to the questions. It's the surgeons who've been doing the cases, who've been feeling the pain and putting in the sweat and tears. They're the ones that will know those little tips and tricks. And you'll find robotic users are really happy to give you all their information and all the little tips and tricks that they have. I think certainly talking to people really helps. In terms of the justifying it, we went through it. The ability to be the one center or the main center that is offering robotics is a big deal for increasing your patient numbers if the hospital is being paid per case, and certainly highlight the efficiencies, and the data is out there in terms of reducing OR time and increasing reducing time to discharge. And I think they're key markers for financial markers that hospitals will want to know about.
Thank you so much for the great speakers we have. Thank you so much.
Thank you. Indeed, it was great presentations and a great session. So Imad, would you please, I think we are going to wrap up in case there is no other burning questions. Moderators, Mike or Roger?
Or more questions, or should we move forward?
Well, if there is no other questions, we just move forward. I would like to ask Imad to finally, Imad, would you please bring up again the slide with the next meeting that we are organizing? So we temporarily will stop the Meet the Expert series because we are organizing this big meeting, which is coming at the end of March, as you can see here. And this is really worthy for you to join if you haven't joined us yet. So please subscribe for this, and it's going to be high value speakers with a lot of experience in spinal tumor surgery. So in the beginning, I have promised you that there will be a surprise for the junior doctors which are with us today. So I would like to ask you one question, and then the fastest will win. So whoever writes in the chat the answers of the question that I'm going to ask you will have a free registration for the course. So it's really worthy, and hope you were very careful watching the presentation. So the question from for today that is coming from Roger Hartel is, what are the successful components of the navigation system? You have to be fast and you have to write in the chat the answer. And the first of you who writes the right answer will be automatically registered for the meeting. Again, what are the successful components of the navigations? You have minutes to give us the question. Please go ahead. I can see questions. I can see that there is answers coming. However, I don't know why I see percentage. The question is, what are the successful components of a navigation system? Anybody? Anybody was careful watching that? Okay, we have one more minute for you to answer.
I think it was a multiple choice. I gave 3 options.
Yes, you have to give us 3 options. You have to have 3 words. In case you don't get, try with 3 words. Anybody?
Nikolai, there was one that from Stacy Darwish that has 3 words. Is that correct or incorrect?
Well, let's see.
Do you see it on the chat? It's the only one I see with 3 words.
So I'm gonna publish now the what is sent from Professor Hartel.
I think let people try again because they just need a hint. What are the 3 components is the question.
Right. Okay. Once again, what are the 3 main technology components of the navigation system?
I think the surgeon-patient team, that makes a lot of sense, but it was based on my talk. So there should be like 3 options for my presentation. I apologize if that's not there, but.
Okay, so maybe I'll give you another hint. So
maybe Nikolai, if you can tell them that the first option is imaging.
Yes, the first option is imaging technology. What are the other 2?
Very good.
What are the other 2 technologies?
Now we're getting those answers. Now we are getting them. So Asad Iftikhar says imaging, navigation, integration.
Okay, so we have answers.
Is it integration? So anytime we use an image guided system, what do we use?
Oh, that's a long answer. We have to analyze that.
3 words.
Okay, so I think that we are getting answers now.
Yep, we're getting closer.
Getting closer. It's getting warm.
Everything is okay.
That's pretty good.
So Roger, you tell us which is the closest answer that we've had here.
Well, I think that Stacy is right on it. She must have taken pictures of my presentation.
Okay, so we have the winner then. So we have the first one who managed to get the right questions. So Stacy is a winner of today's quiz, and we're gonna get back to her with the registration details.
Yeah, so it was navigation technology, planning software, and imaging technology.
I can see there is another question that another answer that came, which was similar, closer, but I think Stacy was first.
Okay, congrats, Stacy.
Okay, thank you, everybody, and I hope you will be with. I hope you enjoyed the webinar today, and I hope you will be with us in March, and you will enjoy even more. I can guarantee you that. Anybody else?
Thank you for organizing.
Thank you, thank you, everybody.
Thank you, Nikolai. Thank you, Mike, for the great moderation, and thank you, Salman, for the great effort done by the World Spinal Column Society on every educational endeavor. And thank you so much for the great speakers we had.
Absolutely. Thank you, Solomon, as well. That's a great job organizing. It's perfect.
All the best.
Thank you, everyone. Everybody did a great job. And both talks were brilliant. Thank you, Paolo. You were great.
Thank you. Bye-bye.
Bye-bye. Bye.